Hello, this is a NAC OSCE presentation about approach to patients with myalgia. I'm Dr. Leila Hosseini, and this has been prepared under the supervision of Starmed Medical Education Program. The resource is up to date. The video content has been made available for informational and educational purposes only, and this content is not intended to be a substitute for professional medical advice, diagnosis, and treatment. About the introduction, myalgia is a common complaint among adults presenting for medical care. In fact, nearly everyone will experience muscle soreness at some point in their life. Among the most common causes, we can think about excessive exertion, trauma, and viral infections. It's important to differentiate benign versus more serious conditions. We should take a thorough history, do a physical exam, and for more severe conditions, some investigations might be required. It's also important to differentiate myalgia from myopathies and myositis and separate diffuse from localized symptoms. Regarding the etiologies of diffuse myalgia, we can think about infections. As we know, they have fever, some viral diagnostic testings might be required, leukocytosis, some rash might be there. The non-inflammatory pain syndromes, the most important one is fibromyalgia for NAC OSCE cases. In these patients, the patient has some tender points, as can be seen here. There are at least 6 tender points from a total of 9 possible sites. And it's also important to know that the patient has sleep disturbances. And these symptoms must be present for at least 3 months. Among the other etiologies, chronic fatigue syndrome is among them. The patient has a profound fatigue without any other explanations. We can also think about polymyalgia rheumatica. It's also one of the most important cases that might be presented as a myalgia in NAC OSCE stations. The patient has acute onset of proximal myalgia along with morning stiffness. This usually happens in patients over the age of 55. The patient has a high ESR, and there will be a prompt improvement after the initiation of a low-dose glucocorticosteroid. We can also think about polymyositis, dermatomyositis. As we all know, they have characteristic rash and elevated CK. We can think about rheumatoid arthritis, systemic lupus erythematosus, spondyloarthropathies, vasculitis. We can also think about some metabolic conditions, endocrine ones like hypothyroidism and adrenal insufficiency. Always think about medications and also psychiatric conditions as the reason for this. Among the localized myalgia conditions, we can think about unusually strenuous exercise or overuse of the muscles. Trauma can be another reason, pyomyositis, myofascial pain syndrome in which the patient has trigger points, some muscle infarctions, which usually happen in patients with diabetes, and compartment syndrome. In this, the patient usually has a history of recent trauma. Regarding the diagnosis, it's common that we cannot find any diagnosis at the initial visit for a patient with myalgia. It's, however, important to be able to rule out serious conditions like bacterial infections, endocarditis, or impending sepsis, in which the patient has fever, chills, arthralgia, diffuse myalgia, and fatigue and back pain. Regarding the history, we should go through all the questions about the pain, like any other pain. We should go through the questions one by one. Did the pain start suddenly or gradually? Was it coming after a trauma or unusually strenuous activity? If the symptoms started acutely and the patient has constitutional symptoms, we can think about sepsis, pyomyositis, flu, or acute hepatitis B. If the symptoms started acutely and the patient has myalgia in neck, shoulders, upper arms, buttocks, and thighs, and it's a senior patient, always think about polymyalgia rheumatica, especially if it's accompanied by morning stiffness. In subacute myalgias, always think about medication-induced ones, the top of which is statin-induced myalgia. It takes weeks to months for the symptoms to occur. Regarding the more insidious onset myalgias and chronic symptoms, we can think about chronic hepatitis C, hypothyroidism, hypercalcemia, fibromyalgia, chronic fatigue syndrome, and also somatization. Is the muscle pain worse in the morning? If so, if the patient has muscle pain and stiffness in the morning, think about polymyalgia rheumatica again. If the patient has pain elsewhere, how the distribution of the muscle pain is. For instance, statin-induced myalgia is proximal symmetric muscle weakness and soreness, while viral infections like flu usually cause diffuse myalgia with fever and headache and malaise. Is there any redness, swelling, or warmth in the area of the muscle pain? Is there any tenderness at that point? We can think about compartment syndrome, pyomyositis, abscess, or muscle infarction. Is there any muscle weakness? Is it difficult to arise from a chair or reach above the head? If the patient has muscle cramps, we should think about some structural disorders, some unusual positioning, some neurologic disorders like Parkinson's disease. Trauma can be another reason, dehydration, exercise, electrolyte abnormalities, and also, again, some medications like statins. Think about associated symptoms. Ask from the patient whether the patient has any constipation, depression, fatigue, fever, any swelling of the joints, or paresthesia, any rash, hyperpigmentation, any weight changes, nausea, vomiting, diarrhea. If the patient has constipation, fatigue, and weight gain, think about hypothyroidism. Rash is indicative of infection. Hyperpigmentation, adrenal insufficiency. Fever has a wide range of conditions like lupus, like infection, joint swelling, arthritis, and paresthesia. We can think about neuropathic conditions. Ask about other history of the patient, the age and the sex. For instance, young adult women with myalgia, we can think about lupus or rheumatoid arthritis, while polymyalgia rheumatica is seen exclusively among adults over the age of 55. Ask about the past medical history of the patient, any recent exposure with patients with symptoms of flu or COVID-19, whether the patient is taking any medications, especially statins, whether the patient had any recent trauma, and also a psychologic assessment is important. The patients with depression or somatization disorders can come with myalgia symptoms. In the physical exam, go thoroughly through muscle examination. If the patient has proximal muscle weakness in all four extremities, we can think about polymyositis, hypothyroidism, drug-induced myopathy, and hypercalcemia. Focal swelling or erythema, we can think about pyomyositis or other infections. If there is a severe localized tenderness without any inflammatory features, think about muscle infarction or compartment syndrome. Also ask about fever, hypotension, hyperpigmentation, postural hypotension, which are symptoms of adrenal insufficiency, cutaneous lesions like lupus or Lyme, psoriasis, endocarditis, ecchymosis, which can be seen in recent trauma. If the patient has limited shoulder and hip range of motion, think about polymyalgia rheumatica. If the joints have any inflammations, think about rheumatoid arthritis, psoriatic arthritis, or lupus. Ask about tender points. Again, fibromyalgia would be the diagnosis. Trigger points, myofascial pain syndrome, whether the patient has severe focal muscle pain, which is compartment syndrome, pyomyositis, and muscle infarction. Delayed relaxation of reflexes is indicative of hypothyroidism associated with other symptoms, of course. Depressed mood, we can think about depression and somatization disorders. Regarding the lab studies, usually watchful waiting would be the best approach. However, if indicated, the initial assessment could be CBC, UA, renal function test, and liver function test. We can go through some other lab studies as well if indicated. For example, if the patient has weakness, we check the patient's CK. And if the patient has cold intolerance, we check the thyroid hormone TSH. And also ESR CRP must be checked for the patients suspicious of polymyalgia rheumatica. We checked autoantibodies like ANA in lupus, ANCA in vasculitis associated with that, rheumatoid factor and anti-CCP antibodies in rheumatoid arthritis. If we are suspicious of adrenal insufficiency, we check the patient's morning serum cortisol or ACTH stimulation test. And about the management, if it's medication induced, just a trial of the medication. However, it takes a while for the symptoms to disappear. If we are suspicious of polymyalgia rheumatica, as I mentioned earlier, a few days of low-dose corticosteroid treatment will make a rapid and dramatic improvement in patients' symptoms. If we cannot find the reason for myalgia and it's not a serious one, just symptomatic therapy like heat, rest, acetaminophen, NSAIDs, and muscle relaxants. If we are suspicious of polymyalgia rheumatica, or if the patient has severe pain or something that is a really serious one, we should refer the patient. Thank you again for listening to this presentation, and have a good day. Thank you. Bye.